Thanks. Is everybody awake? Yeah? All right, thank you. So I just want to talk about the Global Digital Health Certification Network, which is a digital public infrastructure that WHO has now deployed, and how it connects to the, the IPS and some other use cases. So first of all, what is the Global Digital Health Certification Network? It's public key infrastructure that you can use to verify the provenance and authenticity of health documents. Okay, so it's public key infrastructure, so you're talking about having a public and private key pair that you can use to create a signature and check that a health document is who it purports to be from. So it's basically a three-step process to get onto this, to use this trust network. The first is WHO is acting as a trust anchor. So we're reaching out to countries to say, would you like to participate in this network? And if so, you need to share your public keys with us, and we'll make sure that it's really the Ministry of Health Kenya that's sharing the public keys and not some unauthorized actor that's trying to hack into the system. So we take the first step is we verify the organizational identity of a participant in this trust network. The second, and we receive their keys from them. The second step, we've received the keys, now we give them out to all member states. And in fact, they'll be publicly available, they're public keys. But now a country like A, B, or C knows that they have an authoritative record of the public keys from each country. They don't need to go to, if you're from Kenya, you don't need to go to Nigeria and then to Germany and then to Indonesia and ask for their keys. You can get it in one central place. So this really takes down the load of a country trying to participate in the trust network. After the keys have been shared, in step 3, WHO is no longer a participant in any kind of data exchange, but as an individual takes their health record going from one country to the next, they show their health record to provide that health record, and the authenticity of that health record, such as the IPS, can be verified using these public key infrastructure. The WHO doesn't see any health data, it doesn't see any personal data, it's out of the picture, but this is a way that countries can bilaterally check the veracity of these health documents. So what we've done is split up the GDHCN into a sets of use cases or trust domains that are not just the use cases, but also the technical service, the trusted services, the technical specifications, such as an IPS, as well as the jurisdictions and policies, because to change data across borders requires legislation often, right? And it requires permission. And so you might have the same content and the same desires, but you might have different jurisdictions. There might be a European legislation that applies, or a East Africa Commission legislation, or so we need to sort of bundle those together into a trust domain. Right now, we have 80 countries that are already onboarded or in the process of onboarding to the GDHCN, the Global Digital Health Certification Network. So that means that they're ready now to start verifying health documents. The first use case that we had was COVID certificates. This was born out of and built on a lot of the infrastructure that the EU built and 70 some countries participated in during the COVID pandemic, but we've now extended this to other use cases. So the IPS being one of those key use cases. And so what we look for is tourism, just routine tourism, as well as pilgrimage. For example, Hajj, and we'll come to that in a little bit more. Migration, there's forced migration, failed states. How do we ensure that people that are being forced to migrate have health records? Continuity of care for mobile populations. For example, the Pan American region, in this region, there's a lot of mobile populations. How do they bring their health records, and how does a clinician know that that's a valid health record? So, and then vaccination records. So these are sort of the key use cases that we're standing up with the Global Digital Health Certification Network. And we have standards here. So smart.who/trust gives you the specifications and how to onboard. All member states have been invited to join by the Director General last year. So the invitation is outstanding. One key driver, and Fred, how much time do I have? 10 minutes, okay. So one key thing that's happening is the international health regulations. Who knows what the international health regulations are? 1, 2, 3, okay. So who knows what a yellow book is? Okay, you know what the international health regulations are. They're the things that govern the yellow book. So that's an international treaty that all WHO member states have agreed to. In May of this year, there are amendments made to the international health regulations to support a digital version of the Yellow Book. Before, there was no actual legal mandate for countries to exchange globally a digital version of your Yellow Book. So this passed in May. Countries were officially notified that it's going to go into implementation in September. From that date of notification, which was, I believe, September 19th, there's a one-year implementation deadline. So in 1 year, or a little less than 1 year, countries are going to have to start thinking about how to actually make use of the digital vaccine, digital version of the Yellow Book. What's in the Yellow Book? There's a model ICVP, which actually defines the data fields that are in that will be in the digital format. And we've already started using FHIR, the FHIR logical models. Have you talked about logical models yet? Yes? Okay. So we use FHIR to model in a commutable way the data that was in this PDF document. So we have the same data fields expressed in a logical model to say this is the data that is required for the ICVP. And so what we've done is using some of the EU specifications for the COVID certificate, we've modified them and we've added a specific claim for the Yellow Book, for the yellow fever and polio. It should mention that this covers yellow fever and polio, not other vaccines. All the same infrastructure could be used for other vaccines. So we think this is quite exciting because this will be the first instance of a global health document that there's an international treaty that everybody can take and share and use around. So this will be something I think is going to be quite phenomenal once it's in place. The relationship between ICVP and the IPS is we have mappings between ICVP or the Yellow Book and the IPS. So if you have an IPS with the immunization section that has yellow fever or polio in it, that should be a valid way and you should be able to produce an ICVP. Or let's say you have an ICVP and you want to scan it and add it to your health record, it should be compatible and be able to be imported to be included in an IPS record. So we have developed structure maps. Have you talked about structure maps? Yes? Okay. So we have structure maps already defined to go back and forth between the IPS and the ICVP. What we will do is we know that there's a number of regional initiatives. So for example, there's an EU vaccine card project that's starting in January of next year. We're going to be working very closely with them in ensuring compatibility between the EU VAC card and the ICVP. So basically, if you have an EU VAC card, and you show it, you should be able to say, okay, this qualifies as an ICVP. So we want to make sure all of these things work together. And again, how we're going to do this? Logical models, structure maps, concept maps to ensure that we have compatible data. We'll release we'll need to have the ideal is to be able to have a digital wallet that will have your ICVP or your IPS on that. And I think that's coming for the IPS, that's coming in an upcoming Android release from what I hear, if that's a rumor. That the IPS will be on the digital health, the Google Wallet. And so hopefully we'll also get the ICVP on there as well. We'll release a universal verifier app that can scan the ICVP and check against the trust list, against the GDHCN to see if this is an actual valid ICVP. Remember, there's a lot of fraudulent COVID certificates. And there's some news articles now in some countries they're still selling falsified Yellow Books. So how do we actually cut down on this fraud? And this will be an important use case. Next use case I just want to highlight is the Hajj pilgrimage. So this is using the IPS. So you have a pilgrim that's going to Mecca on Hajj, and they start their health journey. They go for a health check in their home country. And when they go to the health check, they get, and we had 3 countries do this in this last Hajj, Indonesia, Oman, and Malaysia. The pilgrims go to the health check. They get explained how to access their IPS and show it when they go on Hajj pilgrimage. And so they go through a consent process, and they create something that's called a verifiable health link, which is very related to this smart health link, which then they can use and show when they receive care. So in Arrow 3, you have the pilgrim is in Saudi Arabia. For some reason, they need to seek emergency care. They show this QR code that links to their IPS document, and that at the EMR in step 4, and that is retrieved and the data sent from the home country into Saudi Arabia for use when they need this care. We added consent directives that describe sort of the sharing from the pilgrim agreeing to share their data out from their home country and for it to be shared within Saudi Arabia and participate in their health system. And all of this relies on the GDHCN. Again, WHO is not seeing any of the traffic, but we're providing infrastructure for checking the validity of the IPS and these QR codes. You can see an example of such a smart health link here. It's just a larger QR code. But if you scan this, you can see sort of, I don't know if that's going to resolve, but you can see how you might try to access an IPS document through a smart health link. I'll pause. I see some. Does anybody have success, or is it not? Scan's bad. Yeah. Okay. But we can also, you'll have the slide deck, so you can come back to this. We basically, with FHIR, and we had a really, in the IPS standard, really allowed us to do very exciting work in a very short period of time. We basically had 3 months of implementation across 4 countries, and we had 300,000 IPS documents produced and shared by pilgrims as they traveled, which, because of the standards, because of the FHIR, because of the infrastructure that's in place, we were able to achieve these really large results. There's an implementation guide that describes it, so smart IPS pilgrimage. You can skip through some of this. The other one I just want to highlight is the Pan American Highway for Digital Health. So that's an initiative by PAHO, supported through the IDB, which is to support continuity of care for mobile populations in the Americas region. And you can see sort of the steps to join the Pan American Highway for Health is to join the GDHCN so that they have the same trust network. So in their priorities for, there's an implementation guide as well for PH4H. We have an IPS validator that we developed to test out the process, and that was tested in a Connectathon last month in Colombia, or is it El Salvador? It was in Colombia. And we had 17 countries participate and join in the dev mode the GDHCN trust network. And next year, the 18 countries have committed to doing the yellow fever card, the ICVP, as well as IPS and telemedicine. And so those are the priorities for next year. So I think the point is IPS is very useful, particularly for these unplanned cross-border care. We're going to be taking it and using it and leveraging it for the ICVP, the Yellow Book. And if you're interested in joining the GDHCN, please come and talk to me afterwards. And I'll just leave it here with the links, and hopefully I'm on time-ish.
That's great. Thanks, Carl. Thanks. So let's have time for a few questions. I mean, I'm hoping that there are probably some developers in the room. I know some technical people, but hopefully you start to see that there's a lot going on in the FHIR ecosystem, right? And there's a lot of like really tangible, practical use cases, obviously at the global and regional level, but like what Carl is talking about, where countries are going to need to understand how to engage with this. There's going to be lots of opportunities, you know, when you have now building towards a standard as opposed to, you know, building towards a kind of a custom data model or something. Lots of opportunities then for other applications to plug into that as well. And so hopefully, if, you know, there is obviously investment in learning about these things, and there's a lot that you can go into in the depth of the FHIR specification. There are obviously opportunities to do that, but hopefully this is starting to form a picture of why it's important to be investing in that, and why it's good to spend some time learning about those things. So let's have a few questions, and then we're going to break for lunch. Any questions? Yeah, Grace.
Since we talked about trust a lot, at the risk of overblowing this, now that in so many countries, including high-income Western countries, things patients can't control, like miscarriages or HIV status, are now being made criminal acts. Can you explain how patient consent for elements like even a medication, which could indicate that you are considered criminal in one country, but not in the original one, How do we handle that? Over.
I think there's two stages to this answer. I think the first stage is an easy stage, and Malaysia did this with the Hajj. So when they go to the patient portal, you basically choose which sections of the IPS you want to share. And even within a section, you can say, choose the medication or not to share, or a prognosis or status. And so you have that. And so in that case, you have one IPS document that's shared. I think the future, looking at things like selective disclosures, like SD-JOTs, will maybe make that a little bit more accessible, and you could share the IPS document with that sort of selective disclosure, not at the front end, but sort of at the back end at the time of verification. But that's a ways away, but we're working towards that.
Thank you very much for the presentation. So the other question that I wanted to ask earlier was about patient IDs. To say we know we have a problem with unique identification of patients. If you make it mandatory for adoption of FHIR, then it becomes, a showstopper really. But currently my question is it possible that a country can actually consume an IPS record electronically without necessarily investing in infrastructure, like a health information exchange, for them to be able to process, because you're really looking at transiting, customers, and you don't really need to invest hugely before you actually can consume that. And then lastly and finally, does the WHO support countries who want to adapt and adopt IPS as a way of processing data for traveling patients? Thank you.
Okay. Patient ID, so just to note, in anything that WHO is doing, we're not making patient ID required. Our identity binding is going to be weak. It'll be up to a jurisdiction to add in maybe a strong, like a national ID or other foundational ID or health ID, but we're not making, because we want to keep, if you look at the paper book, there is no required national ID or passport number that's required on the paper book. So we want to have that symmetry. So we're trying to keep our identity binding weak. On the support question, right now we're trying to identify support. We hope to be able to announce some support to sub-Saharan Africa for GDHCN in general, whether it's IPS or yellow fever early next year. We're trying to identify that funding. It looks very promising. We also believe there will be funding for the EMRO region. In the PAHO region, IDB is providing support for a lot of the work. CIRO and WIPRO, we're still working to identify the funding. And the second question, I'm sorry, was the
ability to read or to consume.
Right. Yeah, so Malaysia is a good example there. So what they said is, oh, we like this global digital health certification network, but we want a Malaysian digital health certification network. So all of their private sector, or what they're doing in the private sector, in the public sector, is they're using that trust network for Malaysia and sharing the IPS, not full, specifically because they knew like the HIE is a 10-year cycle or to implement, and if they can do the IPS quickly, then they have utility up front and quickly. So, and they're doing it now, so, and I think there are a couple people from Malaysia here. If you want some details, I'm sure they'd be happy to explain.
Great. Okay, last question from the question answering thing. When you use the FHIR $validate operation and the request happens to be valid, does this mutate the resource, or do I have to send a new post request? I think that's for you, Diego. When you use the FHIR $validate operation, or does the person who asked the question want to ask the question, and the request happens to be valid, does this mutate the resource? So presumably you've sent a patient resource. Does it mutate that, let's say, or do I have to send a new post request?
Well, if you just do the validate operation, it doesn't do anything, just tell you what the result was. Some servers allows you to, in the moment you are posting a resource, find out if it's valid or not and reject it or not. That can be done by an interceptor in FHIR Happy, and in Google Healthcare you can set different, you can feed several profiles, and if your resource matches any of those profiles, it will be ingested, and if not, it will not. But you have to turn it on or off.
Great.
But it doesn't change the resource. it just get ingested or not. Because your usual,
Yep.
you want the resource to go somewhere, and they can create a barrier for the resource to go somewhere or not, but it will not change the resource.
Great. So it does not mutate the resource, but there are rules that you can apply to determine whether, after that validation, what happens to that resource. Does it get ingested into the server that you're trying to maybe push it to, or does it just send back a message and then your system has to decide how to deal with that? Okay, terrific. Thanks. Another round of applause for all of our presenters. And before we talk about today's breakout sessions, so tomorrow's breakout sessions, there will be a deep dive on IPS, and we'll go through some other use cases and maybe delve into some of these things a little bit more. So that might be something that people are interested in. There'll be another one on smart guidelines. That content will kind of come tomorrow, but that's again something that was mentioned today about the open content and the smart guidelines as an implementation guide, and how you can actually publish an implementation guide, so you'll get hands-on with some of those elements. And then there's also a session that's really going to dive a little bit more into some of the architectural pieces of how do you think about some of the profiling work, some of the validation, how do we think about that, building on some of the mapping and other work that happened yesterday. So I think hopefully we'll build on a lot of what you've heard today and start to bring some of those practical skills as well. After lunch today, these are the breakout sessions that we have. You should all have received an email if you had registered your preferences for the sessions. I'm not sure what the rooms will be today at the moment. So at that registration area where we came in and we've been signing in the morning, we'll just put signs there that will direct you to which session. And hopefully you have that information in your email. If you don't, just come and find me or someone, and yeah, hope you enjoy the afternoon.